Lastly, in this section, I'm going to talk about digoxin. Digoxin kind of deserves its own area because it's an interesting drug, and it's kind of been switched from one particular use in treating cardiac problems to another. Um, but you need to be aware of both uses. So digoxin makes calcium more available in the myocyte, and the way that it does that is it inhibits the sodium potassium ATPase pump. So this is a pump that uses energy. It's basically a slower channel, a slower pump that keeps um, constantly working to keep the sodium and potassium on the correct sides of the cell, um, especially in the resting state, not when it's depolarized. And what it does by inhibiting that pump, it keeps more sodium inside the cardiac muscle cell. That is going to displace calcium that is in a holding area in the cell and makes it more available. And that's going to increase the force of the contraction of the cell. So one of the big side effects is based on how that works. Because we have more sodium being kept in the cell, we have an increased risk for ectopic foci. It destabilizes the cell. The other interesting thing about this drug, this effect that it has on the SA and AV nodes, it has a parasympathetic effect. So if you remember, if we're talking about contraction, that contraction, increased force of contraction, that's a sympathetic effect. But this is a contradictory effect on the SA and AV nodes. It makes them slower. And so it will cause bradycardia. We sometimes use this particular side effect to treat atrial fibrillation. So that makes digoxin, in addition to being a positive inotrope, can also be used to treat an arrhythmia, so antiarrhythmia property of this drug. And that is what it's being used for more and more these days, and less for its positive inotropic effect, because pimobendan's a better drug for this and less side effects. Um, because we have this bradycardia and this effect on the SA and AV node, we can get AV block, atrial ventricular block. And I'll show you what that is. We're going to go to the next couple of slides over here. So we'll start with what first degree AV block is, and that is simply prolonging the PR interval. So if you remember your ECG, we can label 6 different things on it. We have the P wave here, which is the atrial contraction, QRS wave, which is the ventricular contraction, and the T wave, which is the repolarization of the ventricles. So this was depolarization, QRS, and P is repolarization of the ventricles. So we need to look at this PR interval. It's from the P wave to the R wave, and that is a sign we should have a normal length of time. There should be a pause, but it shouldn't be too long. First degree is a prolonging of that PR interval. In second degree heart block, we have a P wave, no QRS wave. Now, in this tracing, we're seeing some normal rhythm here. We're seeing a P with a QRS and a T wave here. And here's another P wave, QRS, T wave. And here's a P wave, no QRS. Then we have another P wave, and then we have a QRS. So the heart is pumping, but we have what is called a missed beat or a blocked beat. And it's just we're going to have occasional missed beats. That's not ideal, but it's not catastrophic. But third degree is pretty catastrophic. Third degree heart block, the P waves are completely dissociated from the QRS waves. So here's a P wave, here's a P wave, here's a P wave, here's a P wave. There's a QRS here and here, but there's no regular interval between them. They are completely dissociated. What's going on is we have atrial contraction, The ventricles are full and they have baroreceptors. And so what happens is what's called an escape rhythm, um, where the ventricles are so full, they're just going to fire on their own. And same thing, P wave, P wave. Okay, we have too much blood. We need to get rid of it. So they're totally independent of each other. That is not a very effective way to pump blood in your heart. So that is what this toxicity can lead to. Digoxin has a very narrow therapeutic index. If you go back to the third chapter and look at what that term means, but basically, we don't have a lot of room to operate. It can too low dose, and we're not going to be effective. Too high, and we're going to be in the toxic zone, and the difference between those two are not very great. That's why it's called narrow. So signs of mild toxicity are going to include vomiting, anorexia, and diarrhea. This is something that you'll see me refer to as VAD. Okay, so VAD is the sign of mild toxicity. We'll also have slight bradycardia. We'll have a prolonged PR interval if we were to hook an animal up to an ECG. And as the toxicity increases, we're going to see that bradycardia be more pronounced. The heart's going to be slower. We're going to have some missed beats, and it can progress to that 3rd degree AV block. Now, in giving this drug to an owner to administer to their animal, the thing that we want to know is we want to pick up any toxicity in this stage. And this is what the owner is going to see. They're not going to see bradycardia. They're probably not going to take their animal's heart rate or know what a normal is. They're not going to see this because we have to hook them up to an ECG. And we sure don't want to get into this area. So when we do a callback, if an animal's being given digoxin, we're going to be asking them whether their animal is vomiting, not eating, having diarrhea. That's where we want to pick up a toxicity. And we're going to tell them about it, of course, as we give them the drug to administer to their pet. But that is the thing that the owner can monitor for in this drug, nothing else. All right, so the thing about digoxin is once we see those signs, and this is where we want to pick up any toxicity, is these signs, we're going to have a long half-life. The drug stays in the system for hours to days. So we need to stop it right away. This is a drug that we can and should stop right away at the first sign of the toxicity. So we want to tell owners if your animal stops eating, if they vomit, if they have diarrhea, you stop the drug and call us. And we are careful in animals that have any renal compromise because this drug is excreted through the kidneys. So we may not use it at all in an animal that has any type of kidney problems. Cats don't tolerate this drug as well. So we will use small doses. Sometimes we'll dose it in body surface area to be as precise as we can. All right, so to summarize, if we have a problem with the heart not pumping effectively, we can use catecholamines short term. We can't use it long term, so we're talking about epinephrine and dobutamine. Only short term. Long term, remember what happens? The cardiac muscle cells become overstimulated. They start pulling in those beta 1 receptors. They don't want to be stimulated anymore. There's nothing for the drug to hit upon, so they become ineffective in a relatively short amount of time. So we'll maintain them typically on pimobendan, potentially on digoxin, but pimobendan has really become the drug that we use more often than not. So CardioSure, Vetmedin is one of the trade names. You can read through this. We're going to talk about some of these other drugs that we can give, ACE inhibitors, which are vasodilators, and furosemide or spironolactone. Those are diuretic drugs. We're going to talk about them in the next section. The reason I put this dense slide in here is to just let you know that we don't use pimobendan by itself. We typically use it with these three other drugs, and you'll find out more about them. But this is pretty typical of treating a heart patient. We will use several different drugs, and that's called a multimodal approach.